So I think nerve injury is such a devastating complication for the surgeon, for the patient's family. So neuroprotective surgery is extremely important. In cases when the anatomy is normal, I think surgeons are fairly comfortable finding that nerve. So in cases where the nerve is encased in scar, then the checkpoint's invaluable, because then you can get an appreciation of where the nerve is by stimulation, and then you can be extra careful and protect the nerve out of harm's way, because nobody wants to damage a nerve. Accidentally, especially, it's the worst. So from a nerve standpoint, the most difficult surgery that we perform is pediatric brachial plexus. So we operate on infants, usually somewhere between 3 months and a year. And we have to make a decision about whether they're going to resect that neuroma, or that big ball of scar, and put nerve grafts in, usually nerves from the legs. Or we're going to free up the scar and decompress the neuroma and then allow it to recuperate on your own. That's perplexing. And you can't tell by just looking at the nerve. Looking at the nerve doesn't help at all. Stimulating the nerve helps, especially if you stick to the low parameters of stimulation, 0.5 milliamps of mid-pulse width, you can make a surgical decision. I mean, one thing that has happened with me in Checkpoint has been it now directly influences my surgical decision-making. So at the time of surgery, it's always on the table, right? And it's pulled up by the nurses beforehand, and we use it in these difficult surgeries. But for me, it's pediatric brachial plexus. Peripheral nerve surgery, it's also very important. Sometimes the nerve will be caught into a fracture site. Well, like we're operating on a kid next week, the median nerve is entrapped into the fracture site. And whether we can extricate or remove the nerve from the callus or scar formation about the fracture, and it'll work, will depend upon, once the nerve is pulled out, does it stimulate? If it stimulates, we go home. If it doesn't stimulate, again, at a low threshold, then we're going to resect that nerve and graft it in this 8-year-old child. So prior to the Checkpoint, the previous models of stimulators were really unreliable. And you couldn't tell, was the nerve working or not, or was the stimulator working or not. That's perplexing, because then you're relying upon whatever, your gut, to make a surgical decision. Now with Checkpoint, as long as that light is beeping on and off and on and off, and we typically check it on the normal nerve first, just to make sure that it's working fine, and then we can ascertain whether or not that nerve is conducting by stimulation. The other problem with the old stimulators was they could damage a nerve, right? And if people held those stimulators against the nerve for too long, because everybody wants to get a response, then that holding on the nerve in and itself could cause damage. The Checkpoint, with its biphasic characteristics, doesn't damage a nerve. The certainty with the previous stimulators that weren't biphasic, that weren't nearly as sophisticated as Checkpoint, was equivocal. At best, it was equivocal. So if you achieved a response, then that was probably a good thing. If you didn't achieve the desired response, again, it was equivocal. I cannot tell you how many old stimulators, and I won't call them by name, were discarded from the table because they didn't work, or I wasn't sure they were working. I had to get another stimulator of the same quality to try and utilize that stimulator, and I just wasn't sure. We even have used our sophisticated SSEP people, the people that monitor the spine surgeries, to use at the time of surgery to cross the neuroma. I found Checkpoint is 1,000 times easier, 1,000 times quicker, and equally, if not more reliable. So the older stimulators were just frustrating, right? And I found myself not relying upon them and not even using them sometime, because my clinical decision at the time of surgery was every bit as good. Now we have an adjuvant treatment. Right now we can use the Checkpoint to help us make a surgical decision. As I said before, I think that's been the biggest change in my practice. Checkpoint is now part of, or routinely used in any of our nerve surgery, either neuroprotective or making a decision whether to resect the neuroma and graft. The other very applicable part of Checkpoint is nerve transfers. So if you take a big redundant nerve, like the ulnar nerve or median nerve up high, and you dissect it out into its individual group fascicles, you need to decide whether the group fascicle that you're going to use for a nerve transfer to a nerve that's not working is, number one, a motor nerve, great use of Checkpoint, and number two, it's redundant. So now, instead of saying, oh, it's at 3 o'clock or 9 o'clock, we piece the nerve apart like string cheese, and then we stim all the group fascicles and make sure that the fascicle we take leaves a fascicle behind that does the same motor function. So that's also been invaluable. So my history with Checkpoint goes back a long time because I've known Kevin Scanlon for years. So we worked together on functional electrical stimulation in spinal cord injury. And when Kevin said to me, I have a product that is better and more reliable and you're going to like it, then we tried it. So I was an early adopter of Checkpoint. Not just because Kevin told me to use it, but as soon as I used it, I saw what a difference it could make. So the question is, was there an aha moment? There are multiple aha moments. So sometimes you'll see a nerve that's being compressed, like under scar or under a ligament. And when you first stimulate the nerve, nothing happens. No muscle contraction. If you then decompress the nerve or release the ligament, and you give it a little bit of time when you come back, and then you stimulate, then you can see a response. And if you see a response, our practice has been then that nerve is left alone. It's not transferred to and it's not grafted. So those aha moments are really important. Now the other real aha moment I think has been to assess whether a nerve, a very critical nerve, is working or not. The classic example for me is the Phrenic Nerve, which is in the neck, and it controls the diaphragm. That nerve needs to be protected when we explore brachial plexus, and especially in babies. So the first thing we do is we find that nerve. We stimulate it with a checkpoint, we make sure it is working, and then we move it out of harm's way. That's done every single solitary time to make sure that nerve is safe. So that's been a huge change in practice. Before, with the less reliable measures or devices, we would stim and it may work, it may not work, but it clearly didn't tell us that that's the nerve that we need to preserve. And what you're really asking me is, do I think in the past we may have made the wrong decision? And the answer is yes. And I think now, using the stimulator, we uniformly make the right decision. And that's what's better for patients, it's better for surgeons, and it's better for families. You know, Kevin, myself, and Len have developed a very special relationship. One classic example is that we have a charity called Touching Hands, and Touching Hands travels around the United States and around the globe taking care of people who don't have insurance. We go to South America, Vietnam, Peru, Africa. We go all over the place. And we ask Checkpoint to donate their devices. And they do, every single time, without question. There's no qualms, there's no hesitation. And I think that mutual relationship has benefited people all over the world. So even where Checkpoint's not distributed, Checkpoints help children and adults making difficult nerve decisions. Checkpoint has clearly changed the way I practice medicine, and it continues to change how I practice medicine. For example, we talked about how we use it in brachial plexus surgery and peripheral nerve surgery to identify and protect the nerves that we're operating on. So currently, yes, it's changed my practice. In the future, it's going to change it more, because as we stimulate these nerves at the time of surgery using the Checkpoint device, then the outcome of nerve surgery will be better, and then everybody's going to be happier. Again, the patients, the families, and the surgeons.